Hello everyone, my name is Megan Fairchild. I go to Arizona State University, and today I will be presenting on how can we help the children trauma and abuse-informed healthcare. The audience for this presentation should be healthcare professionals that may come into contact with children who have experienced some sort of trauma. These professionals could include doctors, nurses, social workers, and child life specialists. Okay, so what is childhood trauma? According to the National Child Traumatic Stress Network, there are 4 main types. Those include abuse, neglect, household dysfunction, and death. Adverse childhood experiences include physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunction such as mental illness, a parent treated violently, divorce, death of a parent, substance abuse, or an incarcerated relative. Complex trauma refers to exposure to multiple traumatic events and the wide-ranging long-term impact of this exposure. Events are severe, pervasive, and often interpersonal, such as abuse and/or profound neglect. The problem we face. There has been a rise in childhood sexual and physical abuse in the past 15 years. Abuse and other trauma exposures can cause multiple negative effects into adulthood for each child affected by a trauma. Reported childhood sexual and physical abuse has risen dramatically. Currently, there are about 1.8 million child abuse reports sent to child welfare nations around the world. Only about 900,000 of those reports will be proven truthful, and the case will be taken to court. This leaves a large number of children that are still left in harmful situations and at risk for further injury or even death. Children with multiple exposures to trauma can develop multiple negative effects that will continue on through adulthood. Currently, there is minimal research done on preventative measures of childhood trauma, as well as cognitive behavioral therapy after the trauma has occurred. Research should continue to develop on how medical and social treatments can be more effective in helping children affected by abuse and/or trauma. So how many children are actually affected? It is estimated that about 3 million children are victims of abuse each year. In 2014, approximately 1,580 children died from abuse and neglect across the country, a rate of 2.13 deaths per 100,000 children, according to the U.S. Department of Health and Human Services. 78% of children had experienced more than one trauma type, and children ages 0 to 3 made up 27.3% of maltreatment victims reported in 2013. The initial exposure for these children, on average, occurred at age 5. Infants are the fastest growing category of children in the foster care system, and once they are removed from their homes and placed in foster care, they are more likely than older children to experience further maltreatment and be in out-of-home care for longer. The traumas these children most often received services for were exposure to domestic violence, sexual abuse, neglect, and traumatic loss or bereavement. Okay, so in a study known as the ACE study, researchers tried to figure out how many adverse childhood experiences individual children had been exposed to. So 36% reported that they had not been exposed to any, 26% reported that they had been exposed to 1, 16% reported that they had been exposed to 2, 9.5% reported that they had been exposed to 3, and 12.5% reported that they had been exposed to 4 or more adverse childhood experiences. So we talked about what those were. Now we are going to talk about their negative effects and how children can have long-term effects that they will carry with them through adulthood. So how does abuse and trauma affect children? It affects children at different developmental stages differently. And with each developmental stage the child reaches, those short and long-term effects are compounded and added onto one another. So for birth to age 3 children, short-term effects include irritability, clinginess, eating and sleep disturbances, and long-term effects include lack of healthy attachments and aggressive or sexualized behaviors. Other effects that this age group may be prone to include somatic complaints, feeling helpless or passive, being difficult to soothe, constricted or repetitive play, developmental regression, general fearfulness or new fears, being easily startled, having a language delay, or talking about the traumatic event and reacting to reminders of it. Often, children of this age can develop PTSD from trauma and abuse, and they will continue to have that throughout their lives. So once again, at each developmental level, the effects of trauma and abuse are different, but they are compounded from one developmental level to the next. So for children ages 3 to 6, short-term effects include fearfulness and passivity, and long-term effects include depression, difficulty concentrating, anxiety, hyperactivity, and poor peer relationships. Other effects that this age group may be prone to include being avoidant or clingy, feeling helpless, having low frustration, being restless, impulsiveness, loss of recent developmental achievements, talking about the traumatic event and reacting to reminders. They are often unable to identify what is bothering them. They can't focus on what they're hearing or learning. They have a difficulty problem solving, which can be a problem when they're in school. They daydream, they're irritable, they have physical symptoms, they have aggressive or sexualized behavior, or they are doing repetitive or post-traumatic play. Okay, so for ages 6 to 11, abuse and trauma affect children a little bit differently. This is when they have started school and they've been in school for a little while. So short-term effects include withdrawal and somatic complaints. Long-term effects include truancy and difficulty in school. Other effects this age group may complain of are difficulty with task completion and concentration in school, school avoidance, nightmares and sleep disruptions, emotional dysregulation, emotional numbing, somatic complaints, and flashbacks of the traumatic event. So, children ages 12 to 18 are teenagers. Short-term effects include self-harm behaviors, school failure, and recklessness. Long-term effects include increased risk of suicide and inability to have healthy relationships. So this is when we start to see how those negative effects are going to carry with them into their adulthood. So children with a history of child abuse and neglect are 1.5 times more likely to use illicit drugs, especially marijuana, in middle adulthood. This is a point when emotional dysregulation is even more prevalent. They are more antisocial. They withdraw from social interactions. They have somatic complaints, and flashbacks are more apparent. The National Institute of Justice study indicated that being abused or neglected as a child increased the likelihood of arrest as a juvenile by 59%. Abuse and neglect also increased the likelihood of adult criminal behavior by 28% and violent crime by 30%. Similarly, a longitudinal study found that physically abused children were at a greater risk of being arrested as juveniles, being a teen parent, and being less likely to graduate from high school. In one long-term study, as many as 80% of young adults who had been abused met the diagnostic criteria for at least one psychiatric disorder by the age of 21. So this is, we see how they're 21, they're adults, and we see all these negative effects are compounding and they are diagnosed with psychiatric disorders. So these young adults exhibited many problems, including depression, anxiety, eating disorders, and suicide attempts. Okay, so this chart is also pulled from the ACE study, or the study done on adverse childhood experiences, and we see how adverse childhood experiences influence health and well-being throughout a child's lifespan. So at conception and on through their life, when a child is affected by adverse childhood experiences, they will grow up with disrupted neurodevelopment, social, emotional, and cognitive impairment, adoption of health risk behaviors, disease, disability, and social problems, and eventually early death. So we see adverse childhood experiences at the bottom, and the more ACEs that a child is exposed to, the more probability there is of an early death and all of these other risks that come with adverse childhood experiences. There are also long-term economic effects to children exposed to trauma or other adverse childhood experiences. The total lifetime economic burden resulting from new cases of fatal and non-fatal child abuse and neglect in the United States in 2008 is approximately $124 billion in 2010 dollars. This economic burden rivals the cost of other high-profile public health problems such as a stroke and type 2 diabetes. The estimated average lifetime cost per victim of non-fatal child abuse and neglect was $210,012 in 2010 dollars, including childhood health care costs, adult medical costs, productivity losses, child welfare costs, criminal justice costs, and special education costs. The estimated average lifetime cost per death is $1,272,900, including medical costs and productivity losses. Research suggests that the benefits of effective prevention likely outweigh the costs of child abuse and neglect. Okay, so I found 3 current approaches to childhood trauma. The first is cognitive behavioral therapy. There has been little research done on cognitive behavioral therapy, but researchers have seen positive results. Currently, studies of the effectiveness of preventative measures and cognitive behavioral therapy on victims of childhood trauma are limited, but more are definitely needed. The second is prevention programs. So researchers have also seen positive results in the evaluation of prevention programs, such as child education and home visitation programs. So this helps for these prevention programs include training for parents on how to work with difficult children or just how to parent in general, as well as visitation programs. So if someone knows a parent is having a hard time, then they will provide education and visiting to help relieve the parent of the problems that they are having so that abuse and trauma will not be as prevalent. And then health initiatives. There have been multiple risks that children with a history of abuse are prone to, which we talked about, and there should be health initiatives that are put in place in order to increase the healthcare staff members' ability to recognize trauma and create treatment plans for children exposed to trauma, in addition to preventative programs for children within the community. So the health initiatives are just kind of starting. They only touch the surface of all of the problems, and a lot of the time doctors don't have the training that they need to work with patients that are victims of complex trauma. So the slide we've all been waiting for, what we need as healthcare providers. So we need further research done on cognitive behavioral therapy and its effectiveness in treating patients with complex trauma or just other adverse childhood experiences. We need further efforts to encourage parental and caregiver support to a child affected by a trauma. And we need further education in working with victims of abuse and/or trauma. So prior research on cognitive behavioral therapy and preventative measures have indicated their effectiveness to counter some of the negative effects of childhood trauma. Further research definitely needs to be done on their effectiveness in relation to childhood trauma. Cohen and Minorino found a strong correlation between decreased negative effects of sexual abuse on young children when parents were supportive of the treatment the child was receiving. So when parents know what's going on in their child's treatment of the trauma, then, and they can add their support to the treatment, then that treatment is more effective. Parents or caregivers, if possible, should be included in the treatment plan for the child after exposure to the childhood trauma. Now, of course, we don't want them involved if they are the ones who participated in the trauma. And then in a survey given to adult women who had been sexually abused, they reported a fear of common medical procedures and health checkups. 65% of them reported that they discontinued going to the doctor at all. So a child has already been exposed to trauma, and the hospital is a new and scary environment. They don't need the trauma added to in the hospital environment. And if we as healthcare providers can be educated, then hopefully they will be more willing to see the hospital as a safe place and come back. We don't want someone to not even come back for regular health checkups because the hospital is associated with that trauma. Social workers, doctors, and nurses, as well as emergency room staff, who are usually the first responders to a sexual abuse, should be taught guidelines in working with victims of sexual abuse or another type of childhood trauma. It is imperative that the medical team be educated on research and interventions for these children with suspected or known abuse histories, so they can work with the family and find a treatment plan to reduce the child's negative outcomes. They need to be educated on research as well as interventions for these children with suspected or known abuse histories, so that they can work with the family and find a treatment plan that will be appropriate for that individual patient and family, to reduce the child's negative outcomes. Okay, so in conclusion, childhood abuse and trauma is very real. It's very prevalent in society, as we have discussed, and unfortunately it's not an issue that's going to be going away anytime soon. Not many measures have been taken to prevent childhood trauma or other adverse childhood experiences from happening, or to lessen the negative impact these stressful events have on children. And unfortunately, children will carry the negative effects of exposure to trauma into adulthood if they are left untreated and unable to process the trauma that they have been exposed to. So next, there is only little research on the effects of using cognitive behavioral therapy on abused children. Further research should be done on cognitive behavioral therapy, as well as preventative measures that can be taken. I think it would be more helpful to stop the fire from happening instead of trying to put out the fire. So I would prefer more research done on preventative measures, but I think it is definitely important to have research done on cognitive behavioral therapy and its effectiveness, just to help those children that we were not able to reach. So third, parents and caregivers should be included in the treatment plan of their child. After a trauma, parents or caregivers should be involved whenever possible. It helps with the coping of the child. Fourth, more education for hospital staff is needed. Hospital staff should be educated on recognizing childhood trauma, treatment options, and how to work with a patient and their family who has been exposed to childhood trauma. So if you are interested in learning more about childhood trauma or its effects, I have compiled a list of additional resources for you. I have found that these can be used by hospital staff to gain more information on childhood trauma, the effects it has on children, and how they can work with these children in decreasing the negative effects of these traumas. So, I really like the National Child Traumatic Stress Network. The Rape, Abuse, and Incest National Network is also very resourceful. The Committee for Children offers tips on how to teach children about safe touch and how they can react to someone who is touching them inappropriately. There's also International Society for Traumatic Stress Studies, American Psychological Association on the Trauma Link, and the National Institute of Mental Health. Thank you all for listening. Here are my references that I used for this slideshow.